Elia, I don't speak Spanish. Sorry, I am learning, but I'm in the process. First, I'd like to thank you very much, not only because you accepted this invitation, but also you stayed here all the time. This is amazing. Thank you very much.
I asked my residents to listen.
Thank you so much.
You're welcome.
And I have two things to say. The first thing, if you had to leave one message, like a take-home message for young researchers, young residents that are watching, like when should we think about CDKL5? So this is the first.
Yeah. Early onset epilepsy with an EEG that is not too abnormal. I think that this is a key thing. We see it also on Dravet, right? We hear the stories of this prolonged seizure, but when you look at the EEG, it is not very abnormal. So I think that they separate in that regard. Also, the kids that present with CDKL5 deficiency disorder, oftentimes there are little things happening even before they have seizures. You hear the story that they are born at term, but they're having some irritability or problem feeding, or they're a little bit more hypotonic than other children. So they come with all these other red flags too, oftentimes. Yes. So again, if the seizures start early and the EEG is no matching the severity of the seizure and how refractory they are, I mean, the majority of my patients, even though they're coming earlier, by the time they come to my center, they are failing 3 or 4 medications. Yeah. You hear the story of what happened when they got in the hospital. They have one seizure, they put one medication, they might very quickly, and they continue to have seizures. And by the time they come to me, they're already on 3 medications, even though they are only 3 or 4 months old. That's a very red flag. The cortical visual impairment is another thing. Yeah. A lot of people confuse with encephalopathy, but the EEG is not telling you that they are encephalopathic, right? They are not having West syndrome. You're not seeing the arrhythmia present on the EEG. So that's early onset cortical visual impairment.
Perfect.
Lateral gaze is very, very early present in these patients. They have the lateral gaze to look at you, lateral gaze preference.
Mm-hmm. So I'll just translate briefly in Portuguese, because some of the people watching do not speak English. Então, as red flags mais importantes, né? Uma epilepsia grave com um EEG que não reflete essa epilepsia, tá certo? Isso é uma coisa para os nossos residentes, para os nossos neuropediatras pensar, porque a gente ainda não conhece o CDKL5 muito bem, tá? Então, assim, tem que lembrar. Essa questão visual, ela é muito marcante mesmo. Tá? Esse déficit cortical visual e do lateral gaze, né? Que é esse desvio meio do olhar que eles têm. Então, só lembrar disso nos lactentes que têm essa epilepsia tão grave, o EEG não reflete, porque esse EEG vai ficar muito ruim só depois, né? Então, no começo não reflete, assim como acontece no Dravet. Another question that I would have to you, and it's about ganaxolone. Actually, I have two questions. One is about the severity scale that you created with Scott from Colorado. Mm-hmm. The severity scale may be approved by the FDA to be used in children. So the severity scale is something that we should validate it in all countries to use too?
I think that would be a good idea. The severity scale is being evaluated by the Center of Excellence in United States and Australia. The group of Dr. Helen Leonard and Jenny Downs that keep the database registry, the international registry, they are also working on the validation of this scale. It's something that is happening. We are on the second phase now, in which we are assessing the patients every 6 months. So last year, we focused on evaluating the patients and doing a retest to make sure that we were measuring correctly the same things, the physicians. And now this year is more looking at how this scale tracks along the disease and tracks many of the symptoms of the disease.
What I can tell you is this scale will be very difficult for parents. Anna knows the scale. I try to apply here for Anna and Bianca, that is in the backstage, and it's very hard for parents, but we can face this challenge.
Yeah, I think that one of the challenges that probably will be solved is that the seizure type. Some parents have their own naming for the seizure types, right? But one of the things that I did some years ago is we make a translation between what they call and what they are, right? So we will be on the same page. So all my patients have, they call it, I don't know what it could be. What the parents call grandma, for instance, may be a sequential seizure. So we look at the videos, we look at what we recorded in the hospital, and we merged together, and we said, this seizure type that the parents call this is truly this.
Yeah, homemade videos can help a lot.
Yes, and that's how we reconcile that, because otherwise we get lost on languages. So.
Yeah, and the last question that I have for you, please, is about ganaxolone. I know that you have a conflict because we are one of the researchers, but does it change a lot for your patients?
So we did the clinical trial, and we enrolled a lot of patients in the clinical trial because basically the parents were very enthusiastic. This was the first drug that came to clinical trial for the disease. And I have to say that many of my patients that entered on the clinical trial are still on clinical trial. I hope that the data of the open label is out there. It has been published in the American Epilepsy Society meeting. What I have to say is there is a reason to try it. We face the same problem that we face with other anti-seizure medications, right? Let's talk about childhood accent epilepsy. Some patients do great with cetosuxamide. Some patients don't, right? Half and half, basically. The same happened for the valproic acid with that disease. So I think we are seeing that problem. The challenge in CDKL5 is that we have a highly refractory epilepsy, that if you find a drug that works, it won't work for a long time. So we have to face both of those problems. And I have a number of patients who are still on the medication, with a reduction of those long seizures, with the sequential seizures, having mostly a small seizure, not using rescue medication for years now. I think there is there is reason to try. If the patient have worsening of the seizure or severe side effects or loss of efficacy over time, well, it happens with the other medications too. One of the things that is important to keep in mind about ganaxolone and about any medication that is tested for any specific etiology is we will get information on how that medication works for that specific etiology, right? If you look at the data of fenfluramine in Dravet syndrome, the efficacy is better than for Lennox-Gastaut. Because on Lennox-Gastaut, we are mixing a lot of different etiologies.
Yeah,
so I think that I am ambivalent when it comes to clinical trials, and we have to decide what we are studying, right? I see the benefit of studying specific etiologies versus studying Lennox-Gastaut as an umbrella. And I see more benefit of studying a particular seizure type versus a particular syndromic or etiology thing. So sometimes I am not happy with what is happening, but I think that it's very important to understand how medications work for specific etiologies. When I start now the new patients of ganaxolone, I know what I'm going to expect from them.
Yeah, I think the problem with Lennox-Gastaut is it's not an etiology. Yes. It's an umbrella term for refractory epilepsy with a certain type of seizure, certain type of AHAs. Yeah. And For sure, patients with a lesion will not work as a CDD patient. It's completely different, a different scenario. And when we don't create these etiology-specific things, we don't know the results. That's how I see things. Okay, thank you very much, Elia.
Very welcome. Yes. I just want to mention, me gustaría mencionar que es el mes de Awareness Month for CDKL5. Y el día, hoy es el día internacional también para reconocer esta enfermedad. La semana próxima, el sábado, también vamos a tener un evento, esta vez en español, y esta vez organizado por el CDKL5 España con el grupo de Estados Unidos. Y vamos a tener un evento educativo. En ese evento vamos a hablar un poquito más sobre el tratamiento y el manejo de la enfermedad. Así que están todos invitados también. El sábado próximo seguimos la conversación.